Hello, everyone. Welcome to SimiTree's webinar. We're going to give everybody just a minute to get into the room, get their audio connected before we get started. So we're very glad you could join us today to hear more about the proposed hospice rule. We've got two of the best experts in the business to talk you through what they have found in this proposed rule. I'm Missy Gilliland, the Director of Learning and Development. We're very glad that you could join us for another one of SimiTree's webinars. As always, we're bringing you two of the best experts in the business. I'm going to turn it over to them in just a minute, but if you have any questions as we go through this webinar, please feel free to use the Q&A. We will be leaving some time at the end to answer questions. And as we're going through the presentation, if they're able to answer the questions in the Q&A, they will. I will be posting the handout in the chat with a link so that you can access all the slides that we're referencing today. With that, we're going to go ahead and get started. I'm going to turn it over to Maureen to introduce herself.
Good morning. My name is Maureen Kelleher. I am a registered nurse by trade and have my MBA, as you can see by my name on the slide. I've been with SimiTree now for 4 years as a senior managing consultant, and I specialize in hospice and palliative care. And I will turn it over to Mike to introduce himself and start our presentation.
Thanks, Maureen. Thank you, Missy. My name is Michael Simione. I'm Managing Director, Financial Consulting at SimiTree. I've been with the organization for over 12 years now. Background is in cost reporting, budgeting, strategic planning, and a lot of data analytics surrounding the post-acute space, home health, hospice, palliative care, and private duty. And to tell the story of the rule being released, we were actually on a very large team call last Thursday afternoon when the rule came out. And if you know my brother, Rob, who is our VP over our consulting division, he was speaking to large room, most of our consulting team. And I had to let him know that he had probably lost about half of the room because the rule had come out in the middle of our team-wide meeting, and made the comment that, one of my favorite days of the year, the proposed and final rule day, just because, obviously we get to see a little glimpse into what the future of the industry holds, and obviously this time of year for hospice. And so interested always to kind of learn ourselves, read the rule and its completeness. I think this year actually we got away with a little bit shorter of a rule than we have in past years from a proposed rule perspective, but still some very exciting and some things on the horizon in hospice that potentially have a big impact on the industry. So today I'll start with, looking at the rate updates, the wage index changes, which are very, very important. I know I've had a few clients already reach out with some concerns about their wage index and future rates for 2025 in hospice and what was proposed. And then I'll turn it over to Maureen, and she's going to cover the hospice quality reporting program updates, of which there are quite a few. The exciting, announcement about the HOPE instrument, which I think is something that everyone involved in the hospice space is interested in learning and hearing more about, and what that impact is going to be, how the EHRs are going to be handling that, and the rollout of that next year. And then the medical director clarification as well. So to start off, we'll go with the rate updates. And I want to say good news. It's not as good as I think some of us would hope, but at least the rates are projected to increase for next year. So they're looking at a proposed $705 million increase in Medicare spending in hospice. That overall increase is 2.6%. And that the hospice cap also going up by that same amount, 2.6%. So the good news here is that some of the things that have been proposed by MedPAC in the past with the change to the hospice reimbursement model and change to the hospice cap, they're not going to be implemented for next year, hospice fiscal year 2025. So the things will remain with the status quo with the, a general increase, that 2.6% increase, both in the base rates as well as the hospice cap. In addition to that, they're maintaining the hospice quality reporting. If you failed to meet those, you have a 4% penalty. So historically, this was a 2% penalty, but last year was the first year that they implemented that 4%. So instead of realizing that 2.6% increase, you'll actually have for your base rate, a 1.4% reduction if you fail to meet the hospice quality reporting requirements. Prior year, that 4% penalty, when finalized, was only a 0.6% reduction versus this year it will be a 1.4. So we're not as significant of an increase from that's proposed for fiscal year 2025 than what was finalized last year. Obviously, we'll see what happens in the final rule, but important to note that 2.6% is slightly less than what we were seeing last year. I think last year was about 750 million increase in hospice spending. So this is the change in the base rates. And so you can see that 2.6%, this comes directly from the final rule in the Federal Register. So routine home care moving from $218 to $223 per day. So a $5 increase per day for the first 60 days. And then day 61 plus going from 172 to 176, so a $4 increase. Continuous care going from 1,565 to 1,610, or, really what is important for continuous, the hourly rate going from 65.23 an hour to 67.10, so just under a $2 increase. Inpatient respite care going from 507 to 518, so an $11 increase, and a general inpatient care going from 1,145 to 1,166, so over a $21 increase in those. So those are those 2.6%, and this is the base rate. So it's important when we look at this that we look at the base rate, but when you're an agency, you have to look at this. How does this impact you locally? And that's what I always like to share when we do these rules is what does that look like locally? And on the next couple of slides after this, we'll look at a couple of areas based on how the wage index changes. So additional items to consider when you're looking at hospice, that 2.6% increase. There's an increased cost of doing business in healthcare right now across the board. Notably recruitment and retention of nurses and clinical staff. And so with the impact of inflation, in your ancillary and vendor cost, as well as wage inflation for your clinicians, as well as recruitment bonuses, retention bonuses, everything you are doing to keep your staff in place so you can service your patients well and fulfill all of the hospice quality reporting requirements that are currently in place and coming that Maureen will talk about. Does that increase that increases significantly the cost of doing business? So does that 2.6% that we're seeing, base rate really justify? And like I said, we'll look at this more locally. Does your own rate changes reflect that cost of doing business? Because if it does not, you need to start looking at operations, looking at efficiency opportunities, productivity opportunities, contract opportunities to see where you can either, maximize revenue or cut costs. If you're on the edge of breaking even and your net margin is, close to zero right now, that's what you need to look at. Otherwise, you might see margins decline in 2025. And obviously, depending on who our board is, who our owners are of our agencies, and, how we're reporting, that we may need to start drilling down into where opportunities from a cost management perspective, from a revenue maximization exist. So the 2023 claims data was used to calculate the 2025 rates, which includes the 2024 wage index. The reason for the 2023 claims, for the 2025 rates, the time lags that are there in terms of the claim submission. So the data that's there, so usually there's a 2-year lag behind what year claims data and or cost report data when it's utilized versus the implementation of the changes for rates. In addition, we're still, some of the data still being leveraged is from the public health emergency. And so, those costs and that time was obviously far from typical. So ideally, within the next couple of years, we'll have a substantial data set of the post-public health emergency to be able to do this. As well, we're seeing interest rates across the board increase, on all from all vendors and everything. So the cost of doing business continues to go up. So that 2.6%, while positive, like I said, I think we were hoping for a bit more, but who knows what will be finalized, but at least proposed. If you're budgeting, we need to start using that number and start forecasting for the future and see, where there may be opportunities if the increase for us doesn't match the increase in cost for our agencies. The good news is they've maintained the 5% cap on wage index reductions. The bad news is if you have a 5% wage index reduction year over year, that is still quite significant, even though at least it's mitigated and it's not 6, 7, 8, or 9%. 5% reduction on wage index. And I've worked with one client in one particular market who's already reached out and obviously showing significant concerns because they're overall are going to be getting about 1% less in 2025 than when they got in 2024 because they have a 4.2% reduction in their wage index. And that is, quite significant to that organization, to that agency, and obviously has a huge impact on their bottom line. So while it's good news that there is a cap on it, if you are at that 5% at the high end of that cap, obviously it has a significant impact for your organization. The wage index value is applied to the labor portion of the hospice payment based on where the patient resides. So your CBSA codes. And just as an FYI, there are transitional CBSA codes in this rule for fiscal year 2025. What that means is those agencies that are at that 5% cap of the wage index reduction, they will have a transitional CBSA code for this year that limits that reduction before transitioning back to their original. So they've done this in the past in both home health and hospice. So it's just important to know that there will be those in place. Looking and reading through the final rule, it's important to, realize and recognize, what CBSO codes you're going to be billing under for your services, starting on 10/1/2025. Obviously, we won't know this for sure until the final rule, but what was proposed, there were several, I think there was 2025 transitional CBSA codes included in the rule. All right, so this is the distribution of the wage index changes. So 35 CBSA codes. So agencies operating in those 35 areas. And if there are specific questions, won't be able to answer them on this call, but feel free to reach out of like, hey, where do we fall in this? And we have this information. Just do not have that information up to date. And that could lead to a lot of questions, but I've already started getting them from clients. But 35 of the CBSA codes are that 7.2% are that 5% wage index reduction. So they're at that cap, that limit. There are 42 additional CBSA codes. So this is your core-based statistical area. Think about it, your geographic area where you're servicing, that goes on your billing codes where your patients reside. Another 8.6% are between a -5 and -3% reduction. 64, 13.1% are between a -3 and -1. And another 124 are between -1 and 0. And that's a quarter. So if we add all of that up, that is over 50% of the CBSAs in the country have a reduction in their wage index. This doesn't mean an overall reduction in their rates, but a reduction in their wage index. This means they're not going to see that full 2.6% increase. And those that are in the -5 and between the -3 and -5, they may actually see a decrease in their localized rates for 2025. The good news for the other, about 46% of agencies that are out there, is they're on the positive side of this. So 7.6 are between 0 and 1%, 7.6% are between 0 and 1, 18.8% between 1 and 3, 8.8% between 3 and 5. And good news for those agencies operating in the 52 CBSA codes that are greater than 5% and have a 10.6% increase. So we have 3 different areas that we're going to show to start this presentation before I kick it to Maureen. But this is if you're working and servicing patients in the Albany, Georgia market, CBSA code 10500. Bad news. You're one of those agencies that has a -5% reduction in your wage index. So we wanted to show something at the high end of the decrease, something that's moderate, and something that's at the that's increasing pretty significantly. So you'll see with the 2.6% increase in the base rate, but the 5% wage index adjustment, which only impacts the labor portion of these, which is why it's different for each of the levels of care. You see that there is a 0.8, 0.9 up to for GIP, a 1.3% reduction in 2025 proposed rule. So those agencies operating in this market and the other trying to remember the number right now. I think it was 30 something markets that have that -5, you're likely going to see about a 1 to 1.5% decrease in your rate, in your localized rate. So obviously, that's not a good thing considering how much cost of care is increasing, as we mentioned previously. Now, if we look at an agency or agencies operating somewhere in the middle, this is Warner Robins, Georgia, 47580, CBSA code. So your information is here. Here's where you're seeing an agency. They're seeing that 2.6%. Basically, the only difference is based on the labor portion of each of these levels of care, as I mentioned, but between a 1.9% increase on GIP up to a 2.9% increase on continuous, 2.5% on routine 1 to 60, 2.3%. So once again, right around what we're seeing from a 2.6% increase, but this is where it's very, very localized. And then we get to the good news, the positive side of things. If we look at the last CBSA code that we're going to look at, Nashville, those of you operating and servicing patients in Nashville and Murfreesboro, Tennessee, this is an agency that has a over 5%, so a plus 5.5%. Luckily, they don't put a cap on the high end. You can go up as much as you want from a wage index, but you're seeing, those agencies see a 6, 5.9, 5.3, up to a 6.9% increase in their base rates. Obviously, significantly, patients are in that routine level. So here, 6 and 5.9% increase. So, if you're operating in this market or the other, 50 markets, I think it's 56 markets that have that plus 5.5, this is really good news because your costs are going up, but your rates are going up at a similar rate. That is all that I have. So I'm going to turn it over to Maureen to talk about the hospice quality reporting program updates.
Okay, thank you, Mike. All right, so the hospice quality reporting HQRP is going to go over some of the changes. There wasn't a whole lot, but there was some big news. So they're adding 2 new quality measures, and these are going to be collected by the new HOPE instrument, which we've been hearing about for at least 10 years. It was called something else. It was called the HEART tool. Then it was the HOPE tool. Now it's the HOPE instrument. But it looks like it may actually be coming into play starting either in October or January, depending on what they come out with the final ruling. But there's going to be 2. One is timely reassessment of pain impact and timely reassessment of non-pain. So for cases where a patient is assessed as having a high, more severe symptom impact, practitioners suggest good care processes include trying to follow up with the patient and having in-person visits, reassessments within 48 hours to ensure treatment has helped alleviate. Now, when I was a hospice nurse and doing actual nursing in the field and in the inpatient units, we always went back and reassessed our patients, especially when they had pain. But now they want us to actually document it, mark it down, and prove that we're doing it. So this is going to be added to the HOPE instrument as a measure that we're going to have to be tracking. So then these measures will determine how many patients were assessed with moderate or severe pain or non-pain impacts, and then were reassessed by the hospice within 2 calendar days. And again, one thing says 48 hours, one says 2 calendar days. Hopefully they'll clarify that with the final rule. Non-pain symptom severity and impact will be determined based on patients' responses to the HOPE data elements related to shortness of breath, anxiety, nausea, vomiting, diarrhea, constipation, and agitation. And only in-person visits would count for the collection of data. So telehealth calls would not count. So if you're making any phone calls and you're asking how the medication's working or what they rate their pain, it doesn't count for this measure. So you're going to have to do an in-person visit, which will increase your visits in some cases. So this is a draft of the HOPE instrument. This is just the one page that includes these 2 measures. It looks a lot like the HIS draft format. So hopefully this is the way they're going to keep it because it'll be easier to incorporate this into our EMR systems. But It's going to ask the question, you're going to have to put the date, and then you're going to have to put how they responded. And then there's the code as to what the non-pain symptom management was. So this is just, we threw this in here. We were very fortunate. They put a sample draft in, and there's going to be a link to find this in Medicare's website. So if you want to see what it looks like, this is what it looks like. If you have your HIS 3.0 version manual that you keep track of the HIS changes, it's very similar looking. So then we get to the actual HOPE instrument. So the HOPE is an ongoing patient assessment instrument that will be used to capture patient family needs throughout the time in a hospice. It's designed to support the hospice conditions of participation, including your QAPI programs, provide quality data to calculate outcome and other types. It's a standardized collection tool that's going to have additional clinical data that will likely inform future payment refinements. So again, everything is going to a value-based process. If we can't prove that we're doing what we're saying we're doing, we're going to find that our rates are going to keep going down rather than up. And we all know the cost of providing healthcare in the home is getting higher, and we don't want to lose reimbursements because people didn't collect the data or submit their quality reporting. Okay. So they're proposing to begin collecting the standardized data information on or after October 1st. They will replace the HIS questionnaire. So once they approve it, finalize it, and say the implementation date, the HIS whole process will go away, and the HOPE instrument tool will actually be capturing a lot of those questions, plus the 2 new questions. And this is something that they will likely tweak every year as they want more and more information, or find that some of the information really doesn't provide them any quality information from what people are submitting. It will collect data from multiple time points across the hospice stay that would inform hospice providers, potentially resulting in improved practice and quality care. The hope is, if we're documenting it, the quality improves. It's going to be collected by hospice staff for each patient admission at 3 distinct times while they're on service. So admission, they're going to have what they're calling an hospice update visit, or a HUV. HUV will be the new acronym you're going to see hanging around, and then at discharge. And the update visit, right now, they haven't clarified how often you're going to have to do that, but it could actually be anytime there's a symptom that is recorded as new or has increased to a moderate or severe level, will need this updated visit completed and then submitted to Medicare. Somebody wrote, "We will love the HUV." So the time point, again, it's dependent on the patient's length of stay, limited to a subset of items addressing clinical issues and important to the care of hospice. Not all HOPE items will be required to be completed at every time point. So again, in keeping with the Reduction of Paper Act, the hope of the hope is that in between a patient's stay in hospice, that we're recording symptoms, and we're recording that we're managing symptoms, so that we can support the concept and the idea that hospice is about symptom management at the end of life, and that we are providing that kind of care to all of our patients. And this is going to be completed and submitted on every patient, no matter who their payer is or how old they are. So if you do pediatrics, it's going to be your peds patients, it's going to be your geriatric patients, it's going to be your in-between. It's going to be Medicare, Humana, Aetna, Cigna, doesn't matter. All your patients are going to have a HOPE instrument completed at least 3 different points. So then they're worried about reliability and validity of the instrument. So it was critical for them to try to find a way to establish this of the measures prior to public reporting. So they want to make sure that as we are submitting our HOPE instrument data, that they can validate and prove reliability for at least 4 quarters before they're going to make the data public. So typically the first 2 quarters of data reflect the learning curve of the providers, and the data is not going to be used to establish validity. So if they start this in October 1st of 2024 for the beginning of the fiscal year 2025, at least that first quarter is going to be giving everybody time to get it done right, to upload it, to make sure it's all coming across correctly. And that information will not be publicly reported. Okay. So what they're proposing in this rule is that data from the first quarter will not be used for assessing validity and reliability. This is just going to be your 3 months of getting it right, getting it submitted, and making sure you have the processes in place. They're then proposing to assess the quality and completeness of the data that we receive as we near the end of Q4 of 2025 before publicly reporting measures. So data collected by hospices for the 4 quarters of fiscal year 2026 will be analyzed and starting in 2027. So it's going to be at least until 2027 before any of this information is going to be publicly reported. They're going to analyze a year of data to make sure it's accurate and reliable, and then they will start reporting it on the Medicare Compare websites. They like to throw a lot of Q1s and Q2s in their data, but that's in essence what it means, is it's not going to be publicly reported until 2027. They created this HOPE instrument by using a technical expert panel. This panel also made suggestions for future measures, so something to keep in mind on what they might be looking at for future questions. Age and diagnosis to ensure comparable representative comparisons between hospices. So everybody with the same age patients and the same diagnoses would be compared equally. Using length of stay, but not functional status, as a risk adjustment factor for hospice performance. They're always focused on how long patients are in hospice. Education that's provided for medication management and wound management addressed in the plan of care. Again, there's going to be a strong focus on care plans. And then CMS will take these recommendations under consideration as they continue to develop HOPE-based quality measures. More updates is the hospices begin the use of HOPE in October 2025 and submit the HOPE assessments. And I apologize, that should be 2024, October of 2024. At the time of implementation, when they actually go into implementing 2020 in October 2025, all HOPE records would need to be submitted as an XML file, just like what you're doing with the HIS. So it's going to be a similar process. I'm going to ask Mike, because I think when we were talking about this, we did clarify that the implementation would be October of 2025, not 2024, correct?
Yes, we've gotten that question in the chat a couple of times. So yes, the proposed implementation, and this is very similar to what they've done in other areas, they're giving you more than 1 year to prepare for the HOPE instrument implementation. So not throwing it on you in March of 2024 for implementation in October of 2024, because it wouldn't even be finalized until June or July of this year. So that gives agencies enough time to become more familiar with it, and even more importantly, probably EHRs and EMRs more time to make sure that it's set up and implemented in their systems for data capturing, and they can work out all the bugs and glitches. Mm-hmm. So this would be starting in 10/1/2025. So calendar year 2025, hospice year 2026. And luckily, as Maureen mentioned on the last slide, they're also giving time to get up to speed, at least a quarter, to get up to speed with it before they're going to start utilizing the data from the HOPE instrument as well.
Right. So once they finalize this, they're going to provide the technical data specifications for software development. You want your EMR systems, you want your wording from your vendors that they are actually going to implement this technical data, all the specifications, and get it ready. And that you want to start at least answering the questions and using it. But until they actually do the implementation, you'll still be required to do HIS. So you may have two separate things to be working on. But again, they're giving you time to get your staff trained, to get them used to using it. It's always best to start using it when you can. And then you're ready for it when it goes into play. Software developers should not wait for final technical specifications to begin development of their own product. And CMS will conduct a call with the software developers and vendors after the specifications are posted. So if the final ruling comes out in July, I would expect the following week the specifications will be out, and then they will start putting up calls for vendors and software developers so they can know what the actual specifications are they need to get into their EMR systems. All right, these are the resources they provided for the updates on the HOPE instrument. And this one that says document/draft HOPE, that's the one where the actual drafting of the tool is. So if you want to see what it looks like from start to finish, you can see on this at this link. Next, CAPS changes, our patient satisfaction surveys. So for in fiscal year 2024 that started last October, CMS presented results of a mode experiment conducted with 56 hospices in 2021. So what they are proposing for beginning with January 2025 decedents is a shorter and simpler survey. They're going to have a web mail mode, so patients would get an email invitation with a link to a web survey. And then if they don't respond to the survey, there would be mail follow-up. And then adding a pre-notification letter, so they would let people know by mail that they would be getting this email invitation, so they can click on the link, and then if they don't click on the link within a certain time frame, they'll mail a follow-up to the non-responders. And then they've extended the time that they're going to leave the survey available from 42 days to 49 days. I'm getting a lot of claps, thumbs up, and hearts, so I'm thinking people are liking this part of it. Okay. I wish I could take credit, but I can't. So, proposed changes to the survey. This is one I'm happy about, the removal of 3 nursing home items and an item about moving the family member. Mainly because people were answering for the nursing home, but it was reflecting against the hospice when it was a negative outcome. So the hospices were getting hit on their quality numbers because families weren't happy with the nursing home. So I'm glad they got rid of this. They're removing one of the survey items regarding confusing and contradictory information for the hospice team communication measure, and that's question number 10. If you have a copy, you can look at the questions. Replacement of the multi-item getting hospice care training measure with new 1-item summary measure. The addition of 2 new measures, which will be used to calculate new care preference measures, and simplified wording to component items for hospice team communication, getting timely care, and treating family members with respect. And the getting timely care one was, did they mean from the time you needed hospice to getting hospice services, or from calling your on-call and getting somebody to come out to the house? And so the question was getting all kinds of different responses. In the proposed rule, table 14 has an actual comparison of what's in the current one compared with the new questions. So if you want to look at that, open up the Federal Register, go to table 14, and it'll give you a whole long, I think it's 3 pages of the questions and what the new questions are. And somebody did write, is it possible to see the draft of the HOPE assessment? There's a link. If you go to that, you can get the draft copy of the HOPE instrument. Okay. Health equity is the other part of this. Again, technical expert panel supported the potential health equity measures of equity as a key organization priority, trainings for health equity, and organization culture. They also recommended that CMS not only measure equity in service, but also equity in access to services. The members raised concerns about collecting hospice quality measure data from family or caregivers rather than collecting directly from patients while they were receiving care, which makes sense. It's the patients who are getting the care. They would know better about whether they were getting the care they were wishing for, instead of asking them 2 months after a patient has died if they remember 3 months ago what kind of care. And vulnerable populations without contacts post-mortem may be left out of data collection, such as hospice patients who do not have family members to help with their care or unhoused people. So they're concerned about, how do we collect data for people where there is no contact after death? How are those people are being left out of the current surveys because there's nobody to send the survey to. Okay. Social determinants of health, again, something we're going to keep hearing for years to come. What they want to have included in the quality measures, which will probably come in future years on the HOPE instrument: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. They're requesting input. So during the comment time that we have now before the finalized rule comes out, is they're looking for input on questions they have regarding the following items on here. And they also listed some potential tools that they might use or incorporate into their tool. But housing instability, food insecurity, utility challenges, transportation challenges, and then there's a tool that crosses all of those domains, and it's Kaiser Permanente's Your Current Life Situation tool. So they may look at something that brings out each one of these individually, or have something that covers all of them. And when you think about it, if you don't have a safe place to live, chances are your care is being affected by that. And our goal in hospice is a peaceful end of life, and not having a place to live, or not being able to afford food, or having your lights turned off could be significant challenges. These are the tools. These are links to all the tools that they provided for those considerations. If you're interested, please feel free. Medicare provided these in the proposed rule. Some additional proposed changes include clarifying medical director. So they identified some discrepancies based on questions they've been receiving from hospices between the medical director condition of participation 418.102 and the payment requirements for certification of terminal illness and the admission to hospice care. Specifically, the industry has been questioning the language and the requirements related to medical directors and physician designees in the conditions, and the physician member of the IDG team in the payment requirements. Excuse me. Okay. So what they want to propose is to amend 418.102 by adding physician member of the hospice interdisciplinary group as defined in 418.56A1I as an individual who may provide the initial certification of terminal illness. And then to amend the medical director to include the medical director or physician designee as identified 418.3. If the medical director is not available or physician member of the IDG among the specified physicians who may review the clinical information as part of the recertification. In other words, it was confusing because it looked as if only the medical director could certify patients and recertify patients. They're clarifying that your team physician and your physician designee who's covering for your medical director, they can all do this. As long as a nurse practitioner or physician's assistant is not certifying terminal illness. At this point, they still cannot certify, but they can write orders and they can be attending providers if the patient chooses them as their attending. Okay. Then they also want to clarify high-intensity palliative treatments. And as a side note, this is not palliative care as a separate service line for symptom management for patients who are also receiving curative treatments. This is palliative treatments that some hospices have been doing for years, where they contract to do adjuvant treatments such as dialysis and blood transfusions for the palliation of hospice patients, chemotherapy, radiation. So the hospices that have contracts to do these, they are usually paying out of pocket for these. And how you pay for those depends on whether you're for-profit or not for profit. If you have a foundation as a nonprofit, you can use that to cover some of these services. The for-profit have to use their regular per diem reimbursements to cover these. But Medicare is acknowledging the increased cost to hospice programs who are providing these treatments to their patients for purposes of palliation of symptoms. So the palliative treatments would be covered if they move through with this, would be covered under the hospice benefit because they are not intended to be curative. That's why it's different from palliative care as a capital P&C, the palliative care subspecialty versus palliative care that all hospices provide. So just keep that in mind when you're looking at this. Okay. So in the 2024 final rule, they noted the response to the RFI on hospice utilization, non-hospice spending. The hospice election decision-making commenters stated providing complex palliative treatments and higher intensity levels of hospice care pose financial risks to hospices when enrolling such patients. As we continue to focus on improved access and value within the hospice benefit, we are soliciting public comment. So again, you go to the final rule, there's a link to where you can add comments if you're concerned and if your hospice does provide these higher intensity treatments for your patients. Go in and comment about how much they cost and what a financial burden it is, because you want them to understand. This is your chance to say, hey, we want to take care of these patients with higher treatment needs, but with the payments we are getting, it is a burden financially and we need help. So please go in and make your comments. Do it as a hospice, do it as an organization, do it as a group, get in with NOC and NHPCO, and they're going to do comments. However you can do it. It's fairly easy to put your comments in for these. What could eliminate the financial risk, and what specific financial risks or costs of the particular concern to hospices that would prevent the provision? For example, is there a cost barrier related to obtaining the appropriate equipment, or is there a cost barrier related to the treatment itself? So if you are contracting with a dialysis company and you're providing dialysis for your patient for the first 2 or 3 weeks, and they're not part of an ACO REACH program that's covering this, how much is that costing you for those patients? And how does that impact your per diem rate that you're getting? If you're getting $150 a day, but your dialysis is costing you $1,000 off. I don't know what it costs because I haven't had to pay for this for a long time, but if it costs $1,000 each day and they're getting it 3 times a week, that's a significant financial impact. Put those numbers in your comments. Okay. Should there be any parameters around when palliative treatments should qualify, and should additional payments only be applicable when the patient is in routine home care rather than GIP level of care or continuous? So those are the questions they're asking. Under the hospice benefit, palliative care is defined as patient family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. In addition to this definition of palliative care, should CMS consider defining palliative services specifically regarding high-cost treatments? So they're not seeking to change the definition of palliative care, but rather considering defining palliative services with regards to high-cost treatments. So it would be likely a payment for high-intensity palliative treatments. Again, the term treatments, not palliative care programs. Should there be documentation that all other palliative measures have been exhausted prior to billing for payment for a higher cost treatment? Should there be separate payments for different types of treatments, or one standard payment? Again, these are the questions they're asking, and this is your opportunity to get the word to CMS about what it's costing you to take care of your patients. And then if you want to learn anything more, or be more specific to your program and what you're doing, we're always here to help. These are Mike and my email accounts. Please feel free to reach out with any questions that we weren't able to answer during this time. And I see there's still a few more, but we do have time left to answer questions.
Yes, so I was going to pose those questions to you, Maureen. I'm going to go in reverse order because I think it's most relevant to what we were just talking about. So question came in. So if we admit patient who is still doing chemo or dialysis for hospice services, the question is, would they still be eligible for hospice care?
So that's what they're trying to determine, is if they're going to have a payment for these treatments. So it would be great if they would. I know I worked for a hospice program that we brought patients in on dialysis, and we covered for 2 weeks. In every IDT meeting, we would determine with our physician whether we were going to continue another while we had the conversations with patients and families about stopping treatment. So that's what they're asking the questions about. They haven't said they will, and they haven't said how much. So right now, they're just gathering information as to whether hospices are looking for an extra payment on these and why.
Next question is in regards to these high intensity palliative treatments. What are some common examples that fall into the category other than dialysis?
Blood transfusions, chemotherapy, palliative chemo, palliative radiation. So a patient with cancer who has a tumor that's causing pain, and none of the pain management treatments are working, and you can do radiation to shrink the tumor, which might reduce the pain. That's an example on a radiation. There's other treatments that some people have looked at. When I was working for the hospice that did them, we did dialysis, blood transfusions. We did IV fluids for a short period of time, paracentesis. Again, some of that, I would include that in there when you're making your comments, because when you do paracentesis, the bottles cost a fortune. And there's a lot of workarounds that are happening out there, but we want to make sure that we keep that a safe process for our patients. So whatever your hospice thinks of that you could do to help with symptom management, include it in your comments, because that's the only way Medicare is. They're not out there doing this with you. That's the only way they're going to know what it is that we are doing for our patients to keep them comfortable.
And another part of that question was, when do we expect the final rule to be released? Last year, the final rule was released on July 28th. So looking at the end of July as the time frame. So there is the comment period that they allow. And basically that started on the day that the rule that was released. I think it's a 90-day comment period. Am I correct in that, Maureen? And then they'll take those comments, circle back, and basically issue the final rule at the end of July. I think potentially beginning of August. I think that gives them it's a certain amount of time before 10/1 that they have to. Typically they like to release these end of the week, end of the day, on a holiday weekend. Last weekend was Easter weekend, and they released it on Thursday, day before Good Friday. So that typically is, I don't know, there's a holiday that I could think of at the end of July, but yeah, end of the week, late in July is most likely when we'll see that.
Okay, I do want to clarify the palliative treatments are related to the hospice diagnosis that they are considering, not things that are not related to hospice. So if you have a patient that's getting dialysis and it's not related to the hospice, Medicare is already paying for that. It's for the patients who are coming on for end-stage kidney disease. Somebody did put a comment in about a patient with CHF. CHF is tricky. You're kind of lucky Medicare covered the dialysis, because if there's any way they can prove that their kidney issues were related to the heart failure and the heart disease, they will likely say it should be covered by hospice. So you want to just be aware of that. If you got them to pay for it, that's great. So it's for hospice related treatments that are for palliation of symptom management, because Medicare expects hospice to take care of all symptoms related to the diagnosis. Okay.
Question on the caps, going back to that, changes to the cap survey, when will those go into effect for what patients? The question is that for patients, deaths occurring on or after January 1st of 2025?
If it's in the final, rule, then yes, it's for anybody who dies on your hospice services from January 1st, 2025 on.
Another question, not sure if we're gonna be able to answer this, but we can try. We recently received a letter from CMS regarding adding medical director as managing employee on Form 855. Do we have any additional information about that?
Well, Medicare requires any managing employee. So if he manages anything related to your hospice program, clinical, other providers, nurse practitioners, if he's writing your policies, if he's doing any kind of management, which your medical director technically is, they want that on there as a managing employee. So yes, it makes sense that they would ask you to do that.
Question on where do we document comments during the comment period?
So you have to go to the actual proposed rule, and there's a link in there that will take you to the page, and then it opens up a blank comment section. You fill in the comment, you can attach files, and then you submit it. It's an easy process. Just make sure you have enough detail in there.
Yes, and it's in the Federal Register, which you can find through the CMS website, a link directly in the rule. So if you go to CMS website and type in 2025 hospice final rule, there is a press release from CMS about the release and the summary. And then at the bottom, there's a link in that will link you directly to the Federal Register. In addition, we got another question, have the wage index been released, the proposed? Yes, they are also on the CMS website. And so once again, searching in there for the proposed wage index files for hospice for 2025, that is where we pulled that information to be able to calculate the county or the CBSA, based rates that were in this presentation earlier. We still have 6 minutes. So going back to the HUV, our new favorite hospice acronym. When can you do the HUV? Is there a specific time?
So they don't have specific times right now. What they are saying is likely anytime a nurse records pain, a moderate or severe pain or other symptom, they're going to expect a follow-up update to show that you did go back after 48 hours or 2 days. but they're not giving a specific time frame yet. And we don't know exactly how they're going to submit them. It looks like it's going to be similar to the HIS files and submissions. It would be really nice if they would keep it that way, because most EMR systems are already set up for that. So it's just a matter of changing the information in the file that goes to Medicare. But we won't know that until they put out the specifications. So the CAP scores, yes. If you don't get a lot of responses, one negative response can detrimentally affect your quality scores, which is part of the problem, which is why they're looking at maybe age and diagnosis and comparing on apples to apples rather than just across the board. But if you're a small program, and sometimes not even small programs, some larger programs, likely you get about 30% return responses. They're hoping that doing a web-based will increase the responses from some of the younger family members who are more likely to be on the computers. I mean, let's face it, if you got a big envelope from a company you never heard of that's got a 56 questionnaire in it, how likely are you to sit down and fill in the circles? Most of us would just throw it away. It doesn't identify the hospice it's coming from. It doesn't identify anything. It just is an envelope. So having a pre-notification and an email explaining what it is might help improve response times.
Another question, we typically send our RN for a 24-hour follow-up visit. Will that cover the 48-hour rule? 24 hours after admission?
From my understanding, it's within 48 hours, so yes. But again, it's not on it. It's if they're having pain or symptoms on admission, yes. If they're not having any identified moderate or severe patients, because I do a lot of chart audits and I see those HIS questions and everybody writes they have no pain, they have no pain. They don't take into consideration that they took their oxy or their Dilaudid an hour before the nurse walked in the door, but they're marking it as none. So the 48-hour or the 2-hour rule is based on pain and other symptoms requiring management that are rated at moderate to high, moderate to severe. So if a patient comes in, they're not in pain on admission, but they come 2 days later, they're calling because they're having pain, you do that visit, and then you have to do another follow-up within 48 hours of that treatment. So keep that in mind. The 48
Clarification, would an LPN count or does it have to be an RN?
They didn't specify, they just said in person. So we're going to have to wait until there's more clarification.
One last, I don't know if it's a question or a comment, but for telehealth, both audio and video will not count in hospice. Not sure if that was a comment or a question.
So not for the follow-up visits for pain, and in hospice, you've never really been able to count any RN visits, telehealth. Social workers, since the PHE is over, social workers are the only ones who can do their visits through audio, video, or phone calls. So you want to make sure that you're not still doing that based on the pandemic rules, because those came out of play in May of 2023.
Excellent. Well, thank you, Maureen and Mike, for answering all those questions. This was great information. As Mike and Maureen said, if you have additional questions, feel free to reach out. Their emails are here. You can reach out. There's additional content that'll be available at SimiTreeHC.com. As always, we appreciate your participation and questions, and we look forward to seeing you at the next webinar.
Thank you. This is
Thank you.
definitely the most questions I've got on a webinar in a very, very long
Me
time.
too.
So appreciate the activity and the shout outs and the I think we had a couple comments in there. We'll have love for the hub and don't be a dope, learn the hope. So really love the participation today. No more.
We may steal those.
Enjoy when we have an actively listening and very eager and interested crowd. So thanks, everybody. Thank you, Maureen. Thank you, Missy. Thanks, everybody, for being here.
Thank you.
Thank you all. Have a wonderful day.